Hi, my name is Chris Mehta. I'm a cardiac surgeon at Northwestern Medicine and an assistant professor of surgery with Northwestern University. I'm also the surgical director of the Bicuspid Aortic Valve Program. This program is unique for a number of reasons. First, we have a bridge program with Lurie Children's Hospital in which young children identified to have a bicuspid aortic valve are monitored during their childhood and then transitioned to our adult program at Northwestern Medicine. In addition, we have a very large registry of patients who have undergone surgery and also patients who are just observing. And this registry is really important for education and for large clinical trials and for other research endeavors. So this was an interesting case. The patient's 32 years old at the time and was passing out at home. He was having syncopal episodes. On his workup, he was found to have severe aortic stenosis in the setting of a known bicuspid aortic valve, and then was referred to us for surgical management. Now, given his young age, we wanted to be really thoughtful about what would be the best treatment option in terms of long-term durability. He was concerned about that affecting his ability to work. He was offered a mechanical aortic valve replacement with the need to be on lifelong anticoagulation. At Northwestern Medicine, we actually offer another option, which is the Ross procedure. Now, the Ross procedure is a very technically complex operation, which is why it's not offered at very many centers. It requires removing the patient's own pulmonary valve and then moving it over to the aortic position where the diseased aortic valve was. Now, to replace the pulmonary valve, we use a donor pulmonary homograft to replace the pulmonary valve. And in that way, we're able to replace someone's aortic valve with their own living tissue instead of an artificial bioprosthesis or mechanical prosthesis. It marries the benefits of long-term durability without the need for anticoagulation like you would for a mechanical valve. We felt that the Ross procedure would be the most durable long-term option for him with the potential fewest needs of future reintervention. Now, when we were in the OR, it turned out that he had an even more rare form of bicuspid valve disease, which was the unicuspid aortic valve. And patients with a unicuspid aortic valve tend to present with severe aortic stenosis even earlier than patients with a traditional bicuspid valve, which is why Evan was only 32 when he presented with symptoms and severe aortic stenosis. His postoperative echocardiogram demonstrates a well-functioning aortic valve with a low gradient across the valve. His pulmonary valve is working really well. The patient had a very smooth recovery after surgery. He was in the hospital for less than a week. He was very satisfied with the procedure. The Ross procedure is another great option for aortic valve replacement that you may not have necessarily considered before, and is really a great long-term durable option, particularly for patients who are less than 50 years old, and is actually the only procedure amongst the three replacement options that has been demonstrated to restore normal life expectancy.